Hello and welcome to this explainer. Today we're taking a really fascinating and honestly, a super important journey into the neurobiology of bipolar disorder. We're going to bridge the gap from its hidden underlying causes all the way to its evidence-based treatments. So whether you're a healthcare student, a caregiver, or, just someone eager to understand mental health on a much deeper level, let's cut right through the noise. We're going to take the complex clinical realities of this condition and make them crystal clear.
Okay, let's dive right into this. Here's our roadmap for today. First, we'll look inside bipolar disorder. Second, causes and risk factors. Third, understanding mood episodes. Fourth, navigating the diagnosis. Fifth, comprehensive treatment approaches. And finally, living well and prevention.
All right, Section 1, Inside Bipolar Disorder. You know how people casually toss around the word bipolar all the time? Like they use it to describe a passing mood, or changing their mind quickly, or even the weather. But medically speaking, bipolar disorder is a chronic and highly treatable mood disorder. The absolute key phrase you need to remember here is far more intense than normal. Look, we all have good days and bad days, right? But the episodes of mania, hypomania, and depression seen in this disorder are severe emotional extremes. They don't just affect a passing mood. They fundamentally disrupt a person's thinking, their behavior, their energy levels, and their daily functioning in a way that regular emotional ups and downs just simply do not.
And this definitely isn't just some modern phenomenon. Surprisingly enough, the ancient Greeks were actually documenting descriptions of mania and melancholia thousands of years ago in antiquity. But the real massive breakthrough? That happened in the mid-20th century with the discovery of lithium. From there, we saw this rapid, late 20th century development of various mood stabilizers, which leads us directly to today's modern, scientific, evidence-based understanding of the disorder.
Moving on to Section 2, causes and risk factors.
Now, what's really interesting is this concept of a broken emotional thermostat. Think of the emotional regulation circuits in your brain kind of like the actual thermostat in your house. In bipolar disorder, structures like the prefrontal cortex, the amygdala, the hippocampus, and the limbic system experience real structural and functional abnormalities. Basically, the thermostat gets stuck. It either blasts the heat, sending the whole system into absolute overdrive, or it just shuts down entirely, plunging the system into a freeze.
But why does that thermostat break in the first place? Well, it typically develops from a very specific collision between biological brain chemistry and environmental stressors. Biologically, crucial neurotransmitters. We're talking dopamine, serotonin, norepinephrine, glutamate, and GABA. They become dysregulated. And this is often heavily linked to genetics and family history. But environmental triggers act as massive catalysts here. Things like childhood trauma, major stressful life events, severe sleep deprivation, and substance misuse can literally trigger that underlying biological vulnerability. It's like a perfect storm.
That brings us to Section 3, Understanding Mood Episodes.
So this is a crucial clinical distinction to make, and honestly, one of the most common points of confusion: the difference between bipolar 1 and bipolar 2. For bipolar 1, the defining feature is that at least one full manic episode is required. Depressive episodes are common, sure, but strictly speaking, they aren't even required for a diagnosis of bipolar 1. Bipolar 2, on the other hand, is completely different. There is absolutely no full manic episode. Instead, a person must have at least one hypomanic episode and at least one major depressive episode.
To truly grasp that, we really have to contrast mania and hypomania. Full mania is an extreme state. We're talking about a severely elevated or irritable mood, impulsive and reckless behavior, a drastically reduced need for sleep, and sometimes even psychosis, like delusions or hallucinations. It severely impairs a person's social and occupational functioning and quite often requires urgent hospitalization. Hypomania shares similar symptoms, like excess energy and rapid speech, but it is distinctly less extreme. It lasts for at least 4 consecutive days, there is zero psychosis, and it doesn't cause that marked functional impairment.
We also absolutely have to address the heavy toll of depressive and mixed episodes. Depressive episodes bring persistent sadness, fatigue, and extreme feelings of guilt and hopelessness. And I really want to emphasize this. There is a high suicide risk associated with these episodes. It makes early recognition and safety planning paramount. Even more complex are what we call mixed features. This is where a patient suffers the crushing weight of depression, but simultaneously experiences the agitated energy and racing thoughts of mania. As you can imagine, it is an incredibly distressing state to be in.
Section 4, Navigating the Diagnosis.
So how do doctors actually diagnose this complex disorder without, just guessing? Well, it's a meticulous, multi-step process. It begins with an extensive medical history and psychiatric interview, which is then followed by a formal mental status examination to meticulously assess appearance, mood, speech, and thought process. Crucially, it also involves lab tests and brain imaging, things like checking thyroid function or performing an MRI. Doctors literally must strictly exclude other medical or neurological issues like hyperthyroidism before they can confirm bipolar disorder.
And to totally eliminate the guesswork, clinicians don't just rely on conversation, they rely on objective, standardized rating scales. Tools like the Young Mania rating scale, the Mood Disorder Questionnaire, or the Hamilton Depression rating scale. These give doctors concrete, actionable data points to accurately measure the severity of the mood episodes and actually track whether a patient is improving or worsening over time.
Now, this objective data is incredibly vital for what doctors call differential diagnosis. It is absolutely crucial to differentiate bipolar disorder from major depressive disorder. Think about it. If a patient comes in during a deep depression, it looks exactly like major depressive disorder. But if a doctor misses a past history of mania and prescribes only an antidepressant, that can actually trigger a severe manic episode. So an accurate diagnosis literally dictates the entire treatment pathway.
Section 5. Comprehensive treatment approaches. So the crucial point to take away here is that mood stabilizers, we're talking medications like lithium, valproate, or lamotrigine, are the absolute cornerstone of treatment. They help level out that broken emotional thermostat we talked about earlier. Doctors might also use atypical antipsychotics or cautiously introduce antidepressants alongside a stabilizer. But honestly, the biggest takeaway from medication management: strict adherence. Sticking to the regimen is vital to prevent relapses even when the patient feels perfectly fine. But medication is only half the battle, right? Adding evidence-based psychotherapy to a medication regimen fundamentally changes patient outcomes. Approaches like cognitive behavioral therapy, family-focused therapy, and interpersonal and social rhythm therapy give patients the real behavioral tools they need to stabilize their routines. Coupled with psychoeducation, this radically reduces relapse risk and just massively improves overall everyday functioning. And it's really important to know that these approaches aren't just fringe science or guesswork. All of these comprehensive treatments are strictly anchored in international clinical guidelines. From the World Health Organization to the American Psychiatric Association and the National Institute of Mental Health, this represents the absolute highest global standard of unified evidence-based care.
And finally, Section 6, Living Well and Prevention.
Let's make this a bit more concrete with a realistic clinical journey. Imagine it starts at a terrifying crisis point, like a young adult being hospitalized for their very first manic episode. It's scary, for sure, but notice the trajectory from there. Immediate psychiatric assessment leads to stabilization through the initiation of mood stabilizer therapy. And from there, it naturally transitions into long-term monitoring, rehabilitation, and family education. It is truly a journey from chaos to a highly hopeful, stabilized reality.
Sustaining that stability, though, requires proactive lifestyle management, and honestly, this is practically medicine in itself. Maintaining a regular sleep schedule is absolutely critical. Disrupted sleep is a massive, massive trigger for mania. Coupling strict sleep hygiene with solid daily routines, avoiding alcohol and recreational drugs, actively managing stress, and utilizing mood monitoring to recognize early warning signs, these are incredible, empowering tools to prevent relapse.
The ultimate medical reality of bipolar disorder is actually deeply hopeful. Yes, it is a complex condition, but it is highly treatable. With the right, comprehensive care, people with bipolar disorder achieve long-term stability, they pursue their biggest goals, and they lead incredibly fulfilling lives. A diagnosis is not an end, it's a pivot point toward recovery.
So, I want to leave you with this final provocative thought. How can early recognition and strong community support fundamentally change the outcome for someone living with bipolar disorder? Clinicians handle the medicine and therapies, absolutely. But awareness, ending the stigma, and creating supportive environments, that is driven by all of us. I really hope this explainer empowered you with the knowledge to better understand this condition. Keep learning and take care of yourselves.